This is Aristea Galanopoulou. I'm a professor at the Departments of Neurology and Neuroscience at the Albert Einstein College of Medicine in Bronx, New York, and I will discuss the contents of the chapter 78 on animal models of epilepsy. Animal models have provided a valuable tool to study pathomechanisms of diseases and help develop treatments to improve the quality of life of individuals affected by them. I will discuss some of the models that are used to study common types of seizures or epilepsies, with special focus on those that may require epilepsy surgery investigations, such as temporal lobe epilepsy, post-traumatic epilepsy, cortical brain malformations associated with epilepsies, special pediatric epilepsy syndromes, or drug-resistant epilepsies. I will also briefly mention examples of use of neurosurgical techniques in models of seizures. Rodent models are the most commonly used animal models of seizures or epilepsies. Rats and mice have substantial biological differences from humans, including a briefer lifespan of approximately 2 years, and brains that lack the typical gyrations seen in humans. Newborn pups are considered as equivalent to full-term human babies around the postnatal days 8 to 13, usually postnatal day 10. This is based on crude estimates on brain growth. Eye-opening occurs around P13 to P15. Puberty starts around P32 to P36 with some sex differences, while adulthood begins around postnatal day 60. However, the maturation of different developmental processes, whether behavioral or motor milestones, trajectories of signaling pathways maturation, neuronal migration, or differentiation and integration, occur asynchronously and with significant differences across species. For example, while humans start to ambulate after the first year of life, rodent pups can already ambulate in their home cage at the 3rd week of life. Comparisons, therefore, across species for various developmental milestone trajectories should be done separately for each studied process. To model temporal lobe epilepsy in animals, different approaches have been used, including electrical stimulation, such as the electrical kindling model, or electrical stimulation induction of status epilepticus, and subsequent appearance of epilepsy. Alternatively, chemoconvulsant models include administration of compounds that induce status epilepticus, which result eventually into the development of epilepsy with similarities to temporal lobe epilepsy. And I will refer to a couple of those models, including canic acid models or pilocarpine models of status epilepticus. The electrical kindling model was first described in adult rodents by Goddard in 1969 as an example of permanent change in brain function resulting from daily electrical stimulation. In brief, the process includes anesthesia, placement of electrodes in hippocampal or limbic regions to facilitate the stimulation of that area, and after repeated electrical stimulation, one can see progressively more severe seizure activity. The progression of the kindled seizure activity includes initial appearance of focal seizures, followed by secondarily generalized seizures until a stage 5 seizure is seen, meaning rearing and falling. This progression is typically described using the Racine scale. A class 1 behavior is mouth and facial automatisms, class 2 is head nodding, class 3 falling clonus, class 4 rearing, and class 5 rearing and falling. There is a modification of the scale introduced by Pinel and Rovner that includes repetitive class 5 seizures, called class 6, circling, jumping, and rolling over with focalization, described as class 7, and class 7 seizures followed by tonus, described as class 8. There are significant genetic and regional differences in the kindling rates, meaning that if you stimulate different brains of the region, it is less or more easy to introduce the kindling state in the animal. And also the genetic background alters the susceptibility to kindling, something that is exemplified by the fast and slow kindled rats that have been described. Although the kindling process is a classical model of epileptogenesis or progression of seizures, only rarely we can see spontaneous seizures, and these have been reported only after hundreds of stimulations. Immature rats are different. Kindling in immature rats was described first in 1981 by Solomon Moshe, and the protocol used is very different compared to the protocol that we use in adults. Immature rats require more frequent stimulations, they have shorter postictal refractoriness periods, and the kindling rates may differ across the developmental ages. In addition, there's different behaviors that one can elicit by kindling of immature animals, as shown here by the scale proposed by the Moshe group, and that includes a stage 0 seizures with behavioral arrest, stage 1 when mouth clonus is seen, stage 2 when head bobbing occurs, stages 3 or 3.5 when unilateral versus alternating falling clonus is observed, stage 5 when bilateral falling clonus without rearing or falling is seen, whereas when we see rearing and falling, this is a stage 5. Wild running and jumping with vocalizations can be seen in some of the immature animals, and it is called stage 6, and tonus can be seen sometimes, and in that case it is called stage 7. Whereas electrical kindling triggers brief seizures typically to induce a state of prolonged seizure activity or status epilepticus, one may use electrical stimulation models of temporal lobe epilepsy. In this case, unilateral or bilateral repetitive electrical stimulation of amygdala, hippocampus, or perforant pathway can be done. Acute seizures may be seen, and status epilepticus can ensue with stage 4 or stage 5 seizures. Mortality is generally lower than in the pharmacologic models of status epilepticus, probably because of the avoidance of chemical compounds that could be also having separate effects, and epilepsy ensues in most of the animals. Seizures in response to sensory stimuli such as auditory or handling have also been reported. Another method to induce status epilepticus and epilepsy is by using chemical compounds that can be excitatory, the chemoconvulsants. An example are the excitatory amino acids that have been used to induce status epilepticus, and these include canic acid, quisqualic acid, and methyl D-aspartic acid or NMDA, homocysteine, and homocysteic acid. To apply them, one can use either focal administration, for example by infusing them in the hippocampus locally, or systemic or intracerebroventricular administration. The canic acid status epilepticus has been extensively used to study the mechanisms, sequelae, as well as screen for treatments for status epilepticus. The acute seizures after the administration of the compound include hypoactivity followed by automatisms, wet dog shakes, scratching, clonic seizures, rearing and falling, or hyperactivity. Tonic-clonic seizures are rarely seen, but with high doses only. Canic acid status epilepticus almost always results in epilepsy when induced in adult rodents, permitting studies on epileptogenesis. And typically after the initial phase of status epilepticus, there is a latent phase during which either no seizures or subclinical seizures, meaning seizure activity that does not have overt behavioral manifestations, may occur. And then in the long term, one can see electroclinical seizures with behaviors that one can observe visually. The pathology of cardiac acid status epilepticus includes neuronal loss, gliosis in the hippocampus, subiculum and entorhinal cortex, dentate cranial cell dispersion, as well as mossy fibrous sprouting, which bear significant resemblance to the pathology that we see in temporal lobe epilepsy or mesial temporal lobe sclerosis that we see in humans with temporal lobe epilepsy. However, there are significant age differences, both in regards to the doses used for induction of status epilepticus, the semiology, the severity, mortality, but also in the resultant pathologies. Another set of models that has similar utility as the cardiac acid status epilepticus models is the pilocarpine models. Pilocarpine is a muscarinic receptor agonist that is derived from Pilocarpus microphyllus plants. Usually, pilocarpine is given systemically, but one can also administer it either focally in the brain or intracerebroventricularly to induce seizures. On its own, pilocarpine can induce status epilepticus at high doses, however, the mortality is significant. To minimize mortality, it is recommended to administer also scopolamine before pilocarpine injection, or to utilize benzodiazepines to stop seizures early. Alternatively, subcutaneous administration of pilocarpine has been used with improved mortality. Pretreating with lithium chloride 18 to 24 hours before pilocarpine, one can reduce significantly the dose of pilocarpine that is needed to trigger seizures and also the associated side effects. This is the lithium pilocarpine model. Similar to the cardiac acid status epilepticus models, the pilocarpine models exhibit the initial period of acute seizures in status epilepticus. Then there is a latent period with either no or subclinical seizure activity, and in the chronic phase there is epilepsy with pathologies that exhibit similarities to the hippocampal sclerosis seen in mesial temporal lobe epilepsy. And in addition, there is a set of comorbidities that one can observe, such as learning disabilities, anxiety, hyperactivity, irritability, and aggression. The post-status epilepticus models have been extensively used to screen for anti-seizure or anti-epileptogenic therapies for temporal lobe epilepsy. It is possible, due to the chronicity of the development of epilepsy, to utilize in vivo methods such as MRI to track brain pathology at different stages of epilepsy development, and this has allowed the investigations into biomarkers of epileptogenesis. For example, Roh and Astrid Nelling utilized MRI imaging in juvenile rats subjected to lithium pilocarpine status epilepticus at postnatal day 21, an age following which some of the animals develop epilepsy and some do not. This allowed them to compare differences between the animals that eventually become epileptic versus those that do not, and the investigators reported that MRI detected injury in the entorhinal and piriform cortices 24 hours after status epilepticus could predict epilepsy development. In another study, the apparent diffusion coefficient changes in the hippocampus a week after status epilepticus was related to epilepsy severity, whereas T2 changes in the amygdala a month after status epilepticus. Different protocols have been used to generate traumatic brain injury in animal models. For more details, you can also read Chapter 376 on animal models in traumatic brain injury. Briefly, these include the fluid percussion injury, controlled cortical impact, weight drop model using a closed skull, impact acceleration model with a closed skull, the blast injury, penetrating injury, and these models can be used either as a single occurrence or repetitively. A popular model of traumatic brain injury is the fluid percussion injury model. There are several variations that depend on the location and the type of craniotomy that one induces. The craniotomy can be central or lateral or rostroparasagittal, and there may be differences in the extent of the craniotomy from 3 to 5 millimeters. The pathology that results may vary, but largely it includes hemorrhages at different locations, corpus callosum, hippocampus, thalamus, brainstem. There is different types of lesions at cortical, hippocampal, thalamic, or amygdala lesions, depending on the parameters of the injury that are used. And also there are inflammatory and other molecular changes that different investigators have reported. There can be a significant mortality depending on the severity of the injury that is induced, that has varied between 10 to 100% in different settings. After the hit, one can see seizure-like behaviors. During the first week after the hit, there may be seizures that manifest, and we call them early seizures, and they do not necessarily indicate the development of post-traumatic epilepsy. Post-traumatic epilepsy typically is spontaneous seizures that manifest beyond the first week after the traumatic brain injury. The rates of post-traumatic epilepsy vary depending on the study, depending on the induction protocol, or the way that the seizures are monitored. In a study from the Pitcairn group using the lateral fluid percussion injury, the post-traumatic epilepsy rate changes with time, and it increases with time. And it may reach 30% of LFPI rats with injury at 6 months of age. Other investigators have reported different rates, although the description of the seizures that are observed is a little bit different, consisting of events that are comprised of theta-alpha patterns that are seen perilesional or bilateral and are not necessarily motor type seizures. The controlled cortical impact model was introduced in the late 1980s by Lighthall and colleagues in ferrets, and it has been since used in different settings. The CCI model, in brief, it has been used in rats or mice, and also at different ages. The injury is induced through a tip that is advanced in a controlled manner through a pneumatic or electromagnetic driven piston. And as the tip advances through the craniotomy, it produces an injury through an intact duna. Again, it can be induced through craniotomies at different locations, whether it is parietal or parieto-temporal, and the pathology underneath is characteristic. There is a significant ipsilateral to the impact necrotic cavity in the cortex, and depending on the parameters of the injury, it can be bigger, including also hippocampal lesions. The behaviors acutely after the injury or long-term can be similar to the behaviors and seizures that one can see with the lateral fluid percussion injury. Different types of seizures have been reported, including motor seizures or non-convulsive seizures, but also generalized spike wave discharges, which, however, can also be seen in controls, although they are believed to be occurring at a higher rate after injury. The blast wave injury model models a more military type of TBI. The animal is placed in a shock tube and exposed to explosive blast, and as a result there is a significant injury both within and outside the brain. It can be done either as a single occurrence or repetitively to mimic repetitive exposure to explosions, and the pathology can include prefrontal cortex, hippocampus, amygdala, and a combination of injury, direct injury, as well as secondary pathologies like inflammatory changes. Acute or early seizures have been reported in up to 50% of the animals, and non-convulsive seizures later in the course have been described in 46%. There is also the penetrating injury model, which is based on the idea that penetrating injuries are more epileptogenic, and also foreign bodies have a significant contributing influence in epileptogenesis if left in the brain. So according to this model, Kinderly and Bertram's group utilized adult rats and generated an injury with a combination of penetrating drill injury and metal wire placement. There was a local lesion in the brain, whereas the animals that eventually developed epilepsy had deeper lesions, such as at the piriform cortex or amygdala. Early seizures were generated in 70 to 83% of the animals, and the post-traumatic epilepsy rate was up to 96% in rats with copper wire in the lesion. That suggested that copper wires may be more epileptogenic. There were no significant post-traumatic epilepsy if steel was inserted after the lesion, whereas the PTE rate was 23% in the animals with only lesion and 15% in the controls. The idea that chemical injury is a significant factor in epileptogenesis was explored in a different set of experiments. For example, studies that used metals such as ferrous chloride in rats, cats. By applying ferrous chloride through injection in the cortex or amygdala, the investigators observed astrogliosis, neuronal loss, iron-stained macrophages, and iron deposits. Up to 90% of the animals developed seizures, whereas epileptic activities developed in guinea pigs but not in cats, suggesting that species is an important factor also in epileptogenesis. The role of aluminum was explored in monkeys. Using alumina chloride epicortically, interneuronal loss and gliosis developed, and in a subset of animals, focal onset seizures were observed. Intracerebral or intracisternal or systemic injection of aluminum compounds in rabbits, cats, ferrets, or rats has also been investigated, and that resulted in cellular degeneration and aluminum deposits, but no epileptic activity in a rat study. Cobalt has also been explored in rats. Rods of cobalt versus aluminum were placed in the cortex, and as a result, inclusions, filamentous intracellular accumulations, and rough endoplasmic reticulum lesions were observed, and spontaneous seizures were seen only in cobalt, but not in aluminum rod implanted rats. Brain malformations can be induced using physical or chemical approaches. In the focal cortical freezing model, which has been used in rodents, focal cortical malformations of four-layered microgyrus can result after the application of focal cortical freezing. If done in utero, there are reports of spontaneous hippocampal seizures that result from this freezing lesion. However, when it is applied postnatally, there is no long-term epilepsy observed. In a different model, in utero irradiation has been applied in rodents and monkeys. And apart from the malformations, heterotopias, or reduced cortical GABAergic interneurons, there have been epileptic seizures reported when frontal or hippocampal lesions are induced. Among the chemical models, the MAM model, or methylaxoxymethanol, this is a DNA alkylating compound, and it inhibits DNA synthesis and cell proliferation. It has been given in rodents and ferrets, typically in a prenatal administration at 15 days of gestation in rats. It results in heterotopias and different other types of malformations, but on its own it cannot produce spontaneous seizures, and as a result a second hit has been introduced, meaning administration of another chemoconvulsant to study how the malformation has the potential of altering the severity or the rate of epilepsy. Combination of MAM and AY9944. AY9944 is a cholesterol synthesis inhibitor. The combination protocol has been used in rats to induce not only heterotopias and dislamination, but also spontaneous, recurrent, atypical absence seizures, otherwise known as slow spike wave discharges. Carmustine, or BCNU, is another DNA alkylating compound that has been administered in rats, results in malformations and also in epilepsy. Focal ibotenic acid, this is a glutamate receptor agonist and indirect GABA-A receptor agonist, has been administered in rodents or cats to induce malformations and heterotopias, but it does not result in spontaneous seizures or hyperexcitability. So all in all, malformations in rats, although they are successful in generating the appropriate pathologies, they do not always result in epilepsy, with very few exceptions, and typically additional factors are needed to observe epilepsy. Additional models of brain malformations include the PTEN mutants. This is phosphatase and tensing homolog tumor suppressor gene mutants that, when induced in rodents as a conditional knockouts in the cerebral cortex and hippocampus, it can generate neuronal and dendritic hypertrophy, increased synapses, and microcephaly. Seizures and spike wave discharges have been reported in 10% of the PTEN conditional knockout mice, whereas the PTEN deletion in adult granule cells leads to epilepsy. Other models include focal mTOR cortical overexpression. This is the mechanistic target of rapamycin that has been implicated in tuberous sclerosis-related epilepsies. As a result of focal mTOR cortical overexpression in mice using in utero electroporation, there is presence of enlarged cortical neurons, neuronal migration defects with cytomegalic neurons, and epilepsy ensures in 90% of the mice, and this is rescued when rapamycin treatment is used. Other approaches to target and disrupt the mTOR pathway include in utero electroporation in TSC1 mice, the Ecke rats, which has TSC2 heterozygosity, conditional knockouts through GFAP of TSC1 gene, other TSC1 models that generate different types of malformations, and also they may have different susceptibility to induced seizures using a variety of models. The GFAP TSC1 conditional knockout model, however, does manifest epilepsy, which is prevented by rapamycin that restores the activity of the mTOR pathway. Another category of genetic mutations or deficits that have been linked with epilepsy and developmental disorders is the ARX mutations. ARX is the aristolase X-linked homeobox protein gene that has been identified in humans in different genetic etiology epilepsies, and it controls migration and differentiation of interneuronal progenitors. In mice knock-in mutations or mice lacking the gene manifest abnormal migrations and differentiations of GABAergic interneurons and cholinergic neurons, and epilepsy has been reported in some of the models, although not in all of them. The double coding models disrupt microtubule-associated protein and result in subcortical band heterotopia and manifest reduced thresholds to induced seizures, as well as epilepsy absence-like in adulthood. Additional genetic etiology models of brain malformations include the filamin A models. This is a gene that helps anchoring actin filaments to plasma membrane glycoproteins. The LIS1 mutant, LIS1 participates in cytoplasmic dynein-mediated nucleokinesis, cell motility, mitosis, and neurogenesis. The TISH mutant, this is autosomal recessive trait for telencephalic internal structure heterotopia. The RELER mutant that has a reelin deficiency, this is a secreted glycoprotein that specifies positioning of postmitotic migrating neurons, and the DEPTEC5 models, which is a repressor of the mTORC1 pathway. DEPTEC5 has been recently identified in dysplasias in humans as somatic mutations that require double hit. All of those models are successfully modeling pathologies that are characteristic of brain malformations. However, not all of them result in spontaneous seizures in adulthood. The ones that have reported epilepsy include the LIS1 mutant. Spontaneous seizures are manifested in 67% of the mice. The TISH mutant, epilepsy with convulsive seizures has been reported, and the DEPTEC5 models, that some of them can manifest spontaneous clinical seizures or tonic-clonic seizures and SUDEP. We're going to switch now to models of early onset epilepsies. I have selected three categories. The one is the models of absence epilepsy that is very common in humans. I will refer briefly to other genetic etiology epilepsies, and finally to models of infantile spasms or West syndrome. In the models of absence epilepsy, the most popular ones are the inbred models, including the Geyer's genetic absence epilepsy rats from Strasbourg and the Wagli Wistar albino Glaxo strain of rats that were maintained in Rijswijk. The EEG pattern that is characteristic of the absence phenotype in these models is the 7 to 11 Hz spike and slow wave discharge that appears in bursts, and typically it is associated with immobility and behavioral arrest. However, it is important to keep in mind that spike wave discharge bursts are also common in many rodents of various strains and sources, including experimental controls. There is a significant species difference also. As I mentioned, the spike wave discharges in the rodents is 7 to 11 Hz. In contrast, in humans with absence epilepsy, specifically the childhood absence, the spike wave discharges have a 3 Hz frequency. So it is always important to remember the species differences. There's many genetic animal models that mimic genetic mutations or variants that have been described in humans. An important category is the Dravet syndrome of severe myoclonic epilepsy of infancy, or SMEI. This is due to sodium channel mutations, SCN1A or SCN1B, and less frequently to GABA receptor gamma 2 subunit mutations. This can be either mutations or knockouts or conditional knockouts. They have been modeled in rodents or zebrafish, and using specific and elegant experiments, specifically knocking those genes out in either interneurons or excitatory neurons, they have been able to demonstrate that disruption of these channels in GABAergic interneurons is important for the development of epilepsy. The seizures can be spontaneous, although more frequently it is the hyperthermia-induced seizures that are studied in these animals, and they have been used for treatment screening purposes. Genetic epilepsies with febrile seizure plus syndrome is a syndrome that manifests with familial history of epilepsies, whether focal or generalized, in different members of the family. It has been attributed to, again, sodium channelopathies, SCN1A or SCN1B. And the animal models manifest more severe canic acid-induced seizures or spontaneous seizures. The progressive myoclonus epilepsy due to EPM1 is modeled by the cystatin B knockout mouse. It manifests widespread granule cell loss in the cerebellum, myoclonic seizures in sleep, and mild ataxia at 6 months that is progressive. The models of infantile spasms or West syndrome have been significantly grown recently over the last several years. Grossly, the existing models, we can classify them into acute models of infantile spasms or epileptic spasms, when they manifest spasms only during the immediate post-induction period, a few hours. And the first model was the NMDA model. NMDA activates glutamate receptors, the NMDA receptors, and it was first known to induce a specific seizure behavior that is called emprosthetonius, like a flexion spasm. Several variations of the NMDA model have been described, and these include combination of prenatal betamethasone with postnatal NMDA, or prenatal stress, prenatal NAM to induce dysplasias, and postnatal adrenalectomy, followed by NMDA administration. Finally, the Down syndrome gamma-butyrolactone or GBL model is induced by administering GBL. This is a GABA B receptor prodrome on a mouse model of Down syndrome. And the investigators reported that results in spasm behavior that can be induced throughout life. The chronic models of infantile spasms include the tetrodotoxin model. This is a sodium channel inhibitor. The ARX models, Aristales X-linked homeobox, is a gene that has been associated with several epilepsies and abnormal GABAergic interneuronal migration and development. The conditional knockout model and a knock-in mouse model have been both described to manifest spasms, but also other types of seizures. And finally, the multiple hit model of infantile spasms has been extensively used to model spasms due to structural lesion, which is the most refractory and poor prognosis type of infantile spasms. And it manifests a sequence of spasms, other types of seizures, several comorbidities including autistic behavior, cognitive problems, and also results in adult epilepsy. In addition, other proposed models of spasms include the APC conditional knockout model. This is disruption of the adenomatous polyposis colon gene, the chronic early stress model, and a TSC1 heterozygous model that in vivo recordings manifested patterns that resembled to infantile spasms. An important concept in epilepsy management is the concept of drug resistance. And this is because this is the definition that triggers the neurosurgical evaluation to identify approaches that can eventually treat the patient or cure epilepsy when seizures do not respond to existing medical treatments. The International League Against Epilepsy a few years ago created a task force to propose the concepts and the definitions of drug-resistant epilepsy to guide the clinical management. And according to that, drug resistance in epilepsy is the failure of adequate trials of two tolerated and appropriately chosen and used anti-epileptic drug schedules, whether these are used as monotherapy or combination therapies, with the ultimate goal to achieve sustained seizure freedom. And seizure freedom was defined as being free of seizures for at least 3 times the longest pre-intervention inter-seizure interval, or 12 months, whichever is the longest. This is obviously creating a challenge for the animal models when we know that the lifespan of a rodent is approximately 2 years of life. And it is also very impractical to implement it in preclinical trials, not only because of the timeline, but also in regards to the power analysis, adequate powering of the studies, as well as resources. As a result, in animal models, drug resistance is assessed as the lack of efficacy of a specific drug to suppress or reduce seizures in a specific model. Sometimes in a given model, we can differentiate responders from non-responders based on the effects of the tested drug. Typically, most of the studies assess one drug at a time, rarely only consecutive trials of 2 appropriate drugs is used to define the drug-resistant epilepsy population. So this already generates some discrepancy between the clinical studies and the preclinical efforts. Moreover, shorter periods of observation are used in preclinical studies to make them more feasible and realistic for the amount of infrastructure and resources that exist. And the measurements of response to a drug are not always seizure freedom, and sometimes they cannot be easily translatable into the clinical situation. There are several models that have been proposed as models of drug-resistant seizures, and a brief example of those is listed in this slide. These include the 6 Hz corneal kindling at 44 milliamps. The kindling, specifically there are lamotrigine or phenytoin-resistant kindled animals. The post-AC models of temporal lobe epilepsy may generate animals that are resistant to certain anti-seizure medications. The dysplasia models using a 2-hit approach may generate drug-resistant epilepsy. There is an encephalitis model, TNEM. This is Tyler murine encephalitis virus that generates seizures that are resistant to drugs. And also in the veterinarian world, dogs can be identified as drug-resistant to certain epilepsy drugs. In this table, I list some of the examples of models that model drug resistance. And as you can see, most of them are focal onset seizures with or without generalization, and most of them are limbic seizures. And these are models in adults. And this may include the amygdala kindling, lamotrigine-resistant amygdala kindling, phenytoin-resistant, post-chymic acid, status epilepticus epilepsy, post-pilocarpine status epilepticus epilepsy, phenobarbital-resistant post-pilocarpine status epilepsy, intrahippocampal chymic acid post-status epilepticus epilepsy, and electrical stimulation of basolateral amygdala-induced epilepsy. And as you can see, most of them are practically characterized based on effects of a drug in the model, and only rarely using a combination of 2 trials of anti-seizure medications consecutively. Apart from the temporal lobe epilepsies, there are other types of epilepsies that are able to generate drug resistance, and this is the atypical absences that sometimes we see in models of refractory in epilepsies, such as Lennox-Gastaut syndrome, for example. The MAM AY9944 model generates this specific type of absence that is resistant against ethosuxamide and valproic acid that are characteristic and effective drugs against the classical absence. The tetanus toxin-induced epilepsy generates focal neocortical epilepsy with cortical myoclonus epilepsia partialis continua, and the model is resistant to diazepam or phenytoin. The TNEV encephalitis model generates handling-induced seizures after viral encephalitis, and it is resistant to carbamazepine. In dogs with drug-resistant epilepsy of genetic or unknown etiology, epilepsy can be resistant against phenobarbital or levetiracetam. And finally, the multiple hit model of infantile spasms or West syndrome is resistant against ACTH and shows partial and transient response against vigabatrin, which are the main treatments for this condition. Finally, investigators have used animal models to study neurosurgical approaches that are used in humans. An example is the corpus callosotomy, which has been studied in different species and models for its ability to stop the propagation of epileptic activity in the cortex, including models of cortical electrical stimulation, focal aluminum oxide cortical application, penicillin seizures in cats, and in the Wistar rat absence epilepsy model. However, the results of corpus callosotomy in animal models is not always advantageous. For example, it increases the seizure frequency and severity in the chronic aluminum model and facilitates the rate of the primary site in the amygdaloid kindling model in rats. In the lithium pilocarpine status epilepticus model, corpus callosotomy reduced the number of animals with seizures or status epilepticus, reduced the mortality, and delayed the onset of seizures. Other surgical procedures that have been tested in animal models include the hemispherectomy, which has been attempted in naive adult rats. Motor deficits were reported at 10 and 30 days postoperatively, although some improvement was noted with time. Cortical resections have also been done in animal models, but paradoxically, they have been tried in a rat model of absence epilepsy, the Wagri rats, in which unilateral resection reduced and bilateral cortical resection abolished spike wave discharges. This is in line with the theory that absence epilepsy or the spike wave discharge of absence epilepsy requires a corticothalamic network, and therefore resection of a cortical component can actually alleviate spike wave discharges. Models are also extensively used for experimental treatments such as gene therapy for epilepsy. Targeted lesioning to probe networks have also been used. Transplantation of GABAergic interneurons has also been tried as a way of treating epilepsy, as a restorative treatment. And also deep brain stimulation has been used. Finally, I hope that I have shown you that epilepsy research has made available numerous models to study temporal lobe epilepsy, brain malformations, epileptic encephalopathies, and drug-resistant epilepsies. Models can be used to interrogate the pathomechanisms of seizures and epileptogenesis and generate new and better therapies. There is an ongoing effort to utilize these models to develop new therapeutic options, mostly pharmacological, although increasing numbers of studies evaluating surgical interventions also appear. Thank you for listening.